Okay, not sure if any of you as your year of residency, whether you're first, second, or third, or fourth, the Army has to offer what's called a financial assistance program. And basically, it's open to physicians, and Sergeant Davis will hand the piece of paper out regarding the financial assistance program. It's open to physicians at any point during their residency training, postgraduate year 2 and above. Provides an annual grant of $45,000 plus a monthly stipend of over $2,200. The active duty service obligation is 2 years for the first year of that participation, plus a 1/2 year for each additional half year of participation with a minimum period of 2 years on active duty. You must be a U.S. citizen in order to apply. And lastly, only very strong candidates with excellent undergrad, medical school GPAs, the United States medical licensing exam scores, and first-time passes. Right? So that's just a little bit more information. At the end of Colonel Chen's didactic lecture on emergency ultrasounds, it will talk about that again, and if you have any questions regarding it, we can speak about it at that time. The second handout should be, and Sergeant Davis is going to hand out, is regarding a CV, a curriculum vitae about Lieutenant Colonel Chen. And I'll go ahead and read it. It's brief. He is currently serving as the Chief Emergency Medical Services, San Antonio Uniformed Services Health Education Consultorium, Associate Program Director for the Emergency and Critical Care Ultrasound Fellowship at the San Antonio Military Medical Center. He received both bachelor's and medical degree at the University of Virginia. So, sir, being that I'm not sure if you're into sports, basketball, football, so I'm in agreement with you as far as the ACC. Completed a transitional internship at Walter Reed Army Medical Center. Subsequently, spent the following year in Korea as a general medical officer until starting the emergency medicine residency from 2005 to 2008. His first post-residency assignment was serving as the Chief of Emergency Medicine at the General Leonard Wood Army Community Hospital. He subsequently completed an Emergency Ultrasound Fellowship at UC Irvine in Southern California. So that's just a little bit about Lieutenant Colonel Chen, and he's going to give you a didactic lecture on emergency ultrasound. The one thing I have noticed in being in recruiting so far, we have liaisons that give us information about residents such as yourselves. And basically, I am aware of nearly 30% of medical residents moonlight or work outside their primary place of employment. Many residents moonlight for professional reasons, including a chance for additional medical experience outside of their residency. But many moonlight and commute great distances, in some cases in order to do so, in order to make additional income to pay off their accrued educational debts. So that's why we talked about the financial assistance program. And if you're interested, we can answer your questions with Sergeant Davis and myself at the end of Lieutenant Colonel Chen's didactic lecture. So without further ado, Lieutenant Colonel Chen.
Good afternoon, everyone. Thanks for having me, Captain Smith.
You're welcome.
Appreciate everyone's attention. As she mentioned, my name's Eric Chin. I'm from San Antonio. We'll be talking about military emergency ultrasound. I imagine most of you in this room are radiologists by training or aspiring radiologists? Yes? Okay. So my goal with this talk is really to kind of give you a little bit of a brief history of military radiology, a very brief one, and then really spend the majority of our time talking about emergency ultrasound, and really to kind of help you learn a little bit more about what it is relative to what you guys do on a day in and day out basis. And then at the very end, we'll talk a little bit about what it's like to be in the military for those who are interested. So for our radiologists here, this gentleman looks probably pretty familiar, I imagine. It's William Conrad Röntgen. He basically discovered the X-ray as it's now known. The military has a very long history with using X-rays and radiology services, particularly when this was invented, purely because they realized that instead of exploring wounds blindly and just sticking things in holes trying to find bullets or injuries wasn't really a good way to take care of patients. with the invention of radiographs, they were able to see through body parts and see where, bullets, fragments were without kind of harming the patient. And so really from the get-go, really 6 months after William Conrad Röntgen published his findings, there were militaries across the world that were trying to get their hands on these devices to use in the battlefield. So fast forward 100 years later, not much really changed. The technology changed a little bit, how they obtained the x-rays, the devices they used, the image processing, and so forth. But it wasn't really until 1982 that the Israelis started to use another form of radiology technology in a combat setting when they basically brought CT scanners into the realm. They had the convenience factor of being co-located to near where their conflict was. And it wasn't really until 1986 that the U.S. Army commissioned the development of a portable CT scanner. This is kind of an ISO container. You might have seen it on a shipping container. It's basically the equivalent. It expands and basically has a CT scanner built into it. This was the first one that was developed and was eventually used in Operation Desert Storm when we went to Iraq. Now, fast forward another number of years, kind of getting to what I'm interested in. In 1995, DARPA, which is basically a research agency within the government, they basically put out calls for technology. They might say, the military says, I think we really need a CT scanner that we could put into a box and ship somewhere. Around 1995, they said, I need a little ultrasound machine that is small enough that someone can carry, is portable and durable. And that led to this, led to this device here, the Sonosite 180. And this is really what revolutionized what I do in emergency medicine. Up until this point, through the 80s and 90s, there were a lot of emergency physicians, trauma surgeons, other non-radiologists using ultrasound at the bedside, but it wasn't really until these devices were invented that this field began to take off, and that's what I'll be talking about today. So, what is emergency ultrasound? Do you guys have any idea, at least from my context? When you hear that term, does that mean anything to you specifically? I think when most people think about ultrasound in general, this is what they think of. They think of a test that some non-radiologist physician orders. The test is typically carried out by a sonographer, sometimes by the radiologist, depending on where you work. And then you guys interpret these images and give out some kind of report. Emergency ultrasound really has many terms that it goes by in the literature. It sometimes is referred to emergency ultrasound. Some people refer to it as clinician-performed ultrasound. Some people call it point-of-care ultrasound or POCUS. And so these smaller devices have really allowed us to bring this kind of device literally anywhere, to any patient in any location around the world. You might see it in, if there's like a disaster, like a hurricane, these companies actually send these devices out for utilization by providers in those locations. This is a little harder to ship out, as you can imagine. So why is this taking off? Have you guys noticed this in your hospital at all? Are you guys seeing this at all? Yes, no?
Yeah, they use ultrasound in the emergency department.
Okay,
Yeah.
good. What about in other parts of the hospital?
In the ICUs, yes.
Yeah, so the greater trend, I think, in the medical field is you're going to see more and more specialties picking up this device, particularly for a number of reasons. If you think back to medical school, we spent at least a year or two trying to master a physical exam, doing anatomy, and kind of trying to feel through the body. And so what was the point of that? What was the point of the physical exam? If you think back, really, what were you trying to do with the physical exam? You were really trying to see into the body. You're trying to detect disease. And the beauty of these devices is, as you know, you can see through the body, there's no radiation, and it's really fundamentally changing the way people can approach patients and diagnose disease. So here are some of the generic reasons I use it for the emergency department, at least. Certainly can make me a better clinician. I'll tell you, my physical exam for a pneumonia is probably 50-50 in terms of being able to auscultate pneumonia. I think most of you would say an x-ray is at least that good or better. Ultrasound is much, much better than that. There are time constraints that we have in the emergency department where we need to move patients through, especially with the increasing volumes that we see in our emergency department. So speed is of the essence. And then some patients actually like us to still touch them and spend time with them. And it turns out the more things you do with them, the happier they tend to be often. So exactly what is emergency ultrasound? Well, the classic definitions are it's usually clinician performed, it's extremely focused and narrowly limited. It can be used in a couple situations, primarily to diagnose acute life-threatening conditions, maybe to help you with the procedure, and then it's contemporaneous with the evaluation and treatment of that patient. Meaning, although you guys might be very fast at obtaining the images and interpreting them and reporting them out, this is truly meant for the clinician who has got a clinical question right that second and wants to know an answer. Specifically, we go for very low-hanging fruit. The types of studies that I do are nowhere near what you guys do. They're not comprehensive, they're very limited and narrowly focused. They answer yes and no questions, and that's it. We don't spend time looking for other things other than the very quick question like, does this person have gallstones, yes or no, and then we move on. So, just to give you a little background on this specialty, currently there are about 175 emergency medicine residencies throughout the country, and among them there are 97 emergency ultrasound fellowships similar to mine. For all ER physicians, they are now required to get training in this particular skill set. And for those of you who are currently going through medical school or have already finished medical school, we're already getting outdated in the sense that there's already 8 medical schools in the country that I'm aware of that use ultrasound throughout their 4 years of their curriculum. From the day one they walk in, they have 20 to 50 machines within their medical school. Some have these little pocket ones that they carry with them around on rounds and so on and so forth. And the idea is that they learn this skill very early on. They use it to help learn the anatomy of patients. They can actually see through patients as they see them in real time. Rather than trying to feel hepatomegaly, they can see if someone has hepatomegaly. It's a very different way of approaching patient care. So this slide here is basically from one of our major organizations in emergency medicine. This is kind of an overview of what emergency ultrasound looks like. When most people think about emergency ultrasound, they think of the diagnostic side, basically what you guys tend to do. But really where I find the most value is these other areas here, the resuscitative, procedural guidance, symptom-based, and therapeutic. Resuscitative being you have a patient who's in cardiac arrest, you want to know, is their heart still beating? That gives me as a provider very prognostic information about whether resuscitation efforts are likely to be successful. Procedural guidance, that would be central lines, paracentesis, thoracentesis, arthrocentesis, anything where you're sticking a needle into someone where you might harm something. This is a great device to reduce the risk of that procedure. Symptom-based, this happens to be my particular favorite. This is really kind of you come in with a patient who might have a symptom. For example, we'll talk about shortness of breath, and then using this device to interpret and evaluate that patient in real time. And then therapeutic, you can actually use, this is not the therapeutic ultrasound that you might be thinking of. This is more for monitoring changes in condition. For example, if I have someone in CHF, I can monitor the diuresis of that patient through ultrasound by looking at their lungs. Here's just a short list of what ER doctors are doing with ultrasound nowadays. This is by no means comprehensive. So I thought one way to kind of bring home what I just mentioned, how emergency ultrasound is a little bit different than what you might expect. I thought I'd go over kind of a case scenario, and then we'll kind of discuss some different ways of evaluating this kind of patient. So we're going to talk about thoracic ultrasound, and in this scenario, we have a 100-year-old lady. She's brought in by EMS. She presents with very severe shortness of breath. Here are some vital signs. A little tachycardic, a little hypoxic, maybe a low-grade temperature, and she's in moderate distress, and with some coarse breath sounds with some wheezing. She looks like she could have CHF. She has a little bit of edema. And the question you have to ask yourself as a clinician at the bedside, what next? So all ER doctors, if you've ever done an ER rotation in your life, and someone asks you, oh, what do you want to do next? Everyone says, throw out a safety net. It's a pretty common answer for us. And what kind of treatments would be initiated in this kind of patient? Well, if the patient looks very sick, maybe they're tripoding, having a very hard time to breathe, the honest answer for most ER doctors is we throw the kitchen sink at them. And this is the old paradigm. We basically don't know why you're dying in front of us, and we just start throwing things at you. We give you oxygen, we maybe put you on BiPAP, we might put you on some nebs, we might give you some nitro or Lasix, or maybe we'll just intubate you because that will take care of your breathing issue, and then we can figure out really what's going on. In my emergency department, if I want to kind of do an evaluation, these are kind of some of the common tests you might order on this kind of patient. You might get a chest x-ray, EKG, aspirin, send off some lab tests. In our department, a chest x-ray will have a turnaround time of at least 60 minutes sometimes. EKG takes some time. And then labs, any labs I order, the turnaround time from when I order it to when it comes back is a good hour to 2 hours. So not very timely when this patient is dying. I don't think they have 1 or 2 hours to hold on, let me wait for that troponin or the BMP. As one of my attendings used to tell me, just get her admitted. Some of us do that. And then, of course, we might consult you guys and get some tests, a CT scan, a VQ scan, and again, maybe intubate this patient. Now, many of you who may be familiar, maybe 15 years ago, there was a movie called Sliding Doors. That's kind of the old way of thinking about things. But what if we could go back in time and change things? The new paradigm would look a little bit like this. The patient comes in, they look like they're dying. I give them oxygen, I put them on BiPAP, and then I apply the emergency ultrasound. So this is the image I get. I put the ultrasound on the patient before I put the stethoscope on the patient. This is a thoracic ultrasound for any of the radiology folks or residents. Does anyone want to kind of interpret this and tell me what they see? Anyone have any ideas? This is, I'll give you a clue. This is basically the probe kind of placed here in the posterior thoracic region.
There's some aerated lung, but there's also some just above the diaphragm, some fluid or fluid-filled. I can't tell if that's fluid-filled lung or pleural effusion, but so there's some. I'm guessing there's some consolidation of the lung, but more severely there's aerated lung.
All right. So we'll go over this image in just a second. So this is what pneumonia looks like. All right. Literally, the patient rolls into the room, and I can diagnose pneumonia before anyone could even call for a stat portable X-ray. And this is profound because this patient I just threw the kitchen sink at, I could say, actually, you need BiPAP and some antibiotics and maybe an intubation, but I don't need to give you nitro. I don't need to give you nebs. That's not going to help this problem. Okay? That's the power of this device, as it's really revolutionizing the way ER doctors take care of patients. You know, a lot of hospitals have time to antibiotics, time to discharge. Those kind of metrics are being tracked. This is extremely helpful when I say I've diagnosed them with pneumonia within 1 minute and I wrote antibiotics within 2 minutes. So this is the image. This is an equivalent image that we just saw. This is really the defining features of pneumonia by ultrasound. Basically, you have alveolar consolidation. Some people refer to it as hepatization of the lung. So when the lung has all the consolidated mucus and pus inside of it, it takes on a fluid-filled consistency. And so instead of being really obscured by all that air, air artifact, you're able to actually see the lung. Okay? The next thing you might see is something called the shred sign. This is basically the border between consolidated lung here and aerated lung here. As you know, air is not a very good friend to ultrasound and really scatters all those rays, so you can't see anything beyond that. Air bronchograms, analogous to air bronchograms you would see on an X-ray. These hyperechoic regions here basically represent air-filled bronchi, and so they scatter and cause those hyperechoic appearances that you might see with air. And then B-lines. B-lines are basically a reverberation artifact due to fluid and edema right there adjacent to the consolidated lung. So as you would expect around a pneumonia, there's going to be a lot of inflammation in those areas. And so that would be the defining characteristics of a pneumonia. So what if I put the probe on the patient and I saw this? What do you guys think about this? Same patient, I'm so short of breath, I can barely say a word. I'm just going to throw the kitchen sink at you, or I'm going to give you the answer. This is the answer right here. What do you guys see? Anything? Same area of the lung I'm looking at, but this time this is what I see. So this is the pleural line right here. You can see it sliding back and forth. This is kind of soft tissue, skin, muscle. We're going between the ribs. You might see a little rib shadow over here. It just came into view on the corner here, created a shadow. These are called B-lines. And again, as we talked about in the last slide, this is what interstitial edema looks like. So this patient, if I saw this in all lung fields, I put the probe on their back, I start looking everywhere, that tells me right away with a high specificity and a high sensitivity that they have CHF. So instead of, again, throwing the kitchen sink at them, I can give them Lasix, nitro, aspirin, maybe BiPAP, and I've given them the appropriate therapy rather than throwing everything at them. All right? Do these images look familiar, or is this pretty novel? I wasn't sure if you guys have seen these kind of images before.
I would say this is novel for me.
Okay.
Oh.
That's good, actually. That was my goal because, you know, I'm not going to tell you how to do your job. Certainly, I would never do that. What if I saw this image? Same patient, look at them, and I see this. So these lines are what are called A lines. So there's B lines, so there must have been A lines. A lines are basically, again, another reverberation artifact. This is a rib with a rib shadow, rib shadow. This bright white line is a pleura. And with any kind of reverberation, you see these kind of equidistant lines here. This tells me there's normal aerated lung under there. Okay? So right away, I know this person has no CHF. They have no pneumonia in this area of the lung. And so that leaves one other big category or therapeutic category for me. That means they're either asthma or COPD. Okay? Particularly if I see lung sliding, I know there's no pneumothorax here. And I'll show you later on, as part of our talk goes on, I'll show you how to look for a pneumothorax with ultrasound. So all this data came out of a study by a guy named Lichtenstein. I believe he's somewhere in Europe, I'm guessing by his name. Came up with something called the Blue Protocol. With this study, he basically looked at these different techniques of evaluating lung ultrasound. And these are some of the numbers he got for for asthma, all right, 89% sensitivity and 97% specificity. Those diffuse B lines that we talked about for CHF, it's 97% sensitive, 95% specific. And then there's some other tricks you can do with this, which we'll talk about in a minute. So this is what it looks like. He has a more formalized zone region. As you know, with research, you kind of have to, you can't just say, well, we put the thing all over their body. He has zones that he looks at. But really, clinically, when I see a patient, I see someone being rolled across to a room that looks like they're dying. I bring my machine with me. I bring it up, put it on their back, and I look at their lungs. And this is what I'm looking for, these kind of things here. These are the A lines that I talked about. This is what it would look like in M mode. The same exact thing. These are an example of the B lines. B lines are characteristically defined by, usually they're at a depth of about 16 centimeters typically.
Doctor,
Yes,
can
please.
you explain a little bit more on that M mode?
Yes.
Can you
So
tell us what you see?
absolutely. So basically, you take the same probe, you hit M mode, and you, as you know, that line basically is plotted over time. So this is basically the same image plotted over time. What you're looking for is a bright hyperechoic line here. That is the pleural interface. So when I'm creating this image, I put that M mode line across there between the ribs. So this is a rib, and those are the rib shadows. So I want it in between the ribs, and this is the image that I'll create. This is what aerated lung looks like. And I'll show you when we talk about the pneumothorax, what a pneumothorax would look like. But we're basically looking for this pleural line here. But this tells me the same thing, that there's normal aerated lung there. And I'll show you some more in a minute. So these are the B lines. These are basically, there's something called Z lines. Are you familiar with Z lines? Or comet tail artifact. Okay, so comet tail artifact is, at least in my specialty, that's kind of, we don't like using that term anymore because it's ambiguous. And so we've kind of broken things down into A lines, B lines, and Z lines. Z lines we'll talk about when we talk about pneumothorax. These are B lines. B lines basically go from the pleura all the way down to the bottom of the screen, typically set at 16 centimeters. Is the traditional distance. We typically use a phased array probe of some sort, or curved probe, or a microconvex, and basically lines that go from here to the bottom, and if there are 3 or more in any field, that is consistent with interstitial edema. Now there are many causes of interstitial edema. If it's all over in all their lung fields, that's CHF. If it's focal, that could just be focal edema. It's sometimes associated with atelectasis. If you see so there are different patterns to choose from, but really, this tells me there's interstitial fluid in that lung field that I'm looking at. And please, if you guys have any other questions, please feel free to stop. So here's another kind of systematic review of basically what we just talked about, looking for pulmonary edema with ultrasound. In this meta-analysis, for acute cardiogenic pulmonary edema, it's 94% sensitive, 92% specific. Much better than any X-ray we could get that we would typically get for these patients in most hospitals in the country as of today. So this is the future. So talking about ultrasound for pneumothorax. So how good is a supine portable chest X-ray, AP, for pneumothorax? So in my trauma center, every single trauma patient comes in, we get a chest X-ray looking for pneumothorax, just by habit. We do a lot of things out of habit. That's just how medicine is. How good is it? Any ideas? So this particular study quoted a very wide sensitivity. If someone has a pneumothorax, I prefer not to have a 28% sensitivity, preferably. How about ultrasound? What do you guys think? What would be a reasonable improvement over 28%?
In the high 90s.
Yeah, that's actually right. So this study's a little older, but there's some more recent meta-analyses that basically peg the number through about 20 different studies, around 91% or so for sensitivity. Specificity is about the same. It's very specific. There aren't too many things that will throw you off, and I'll show you how this works in a second. So here's another study. This was one of the very early studies that kind of got this train going, and they had very optimistic numbers, 98 and 99%. That's probably a little more optimistic than real life nowadays. So how's this done? It's extremely simple. In fact, I do a number of studies with this, teaching medics how to do it, non-medical people how to do it. It literally takes about 2 minutes to do this scan. You take a high-frequency probe similar to this. You basically look for the intercostal spaces. You kind of orient it in a cephalad caudal orientation, typically with the probe indicated towards the head, as you would know. And then you basically follow the midclavicular line. And you basically just follow their respirations through. And so what am I looking for? I'm looking for 3 things to tell me whether there's a pneumothorax or not. First one is I identify the pleural line. I want to see if it's sliding or not. And then if I'm using M mode, I'm looking for something called sky, ocean, beach. And I'll discuss that in a second as well. So this is what a typical ultrasound will look like in B mode or 2D mode. You'll see basically a rib with a rib shadow, rib shadow. You're looking for this bright hypercoic line, the pleural interface. All this stuff down here, as you know, is really nonsense. This is all artifact because the air just scatters everything. You can't see anything. So all you're really seeing is the pleural line, but yet that tells you a lot. You know, I would say 25 years ago, if you talk to most radiologists, sonographers, they would say, don't even bother looking through the lung. You can't see anything. Some brilliant people figured out, oh, actually you can find some things out. And they were able to kind of elucidate this method of analyzing the image. So once you find this pleural line, you're looking for a couple things. You're looking for lung sliding and something called common tail artifact. Similar to those B lines that we're shooting down, they're much shorter and narrower, and you'll see those sliding back and forth. Those are artifacts that will basically tell you there's lung sliding there and therefore no pneumothorax. And so the absence of these things tells me there is a pneumothorax. So how does this work? So you take the probe, you put it on the chest, it looks a lot like this. You see the sliding back and forth. So as someone breathes, their visceral and parietal pleura are rubbing together at all times in a normal person. So that friction is what the ultrasound is interpreting. It's seeing that shimmering pattern back and forth. That tells me there's no pneumothorax. I can guarantee you there's nothing that can do that unless you have 2 pieces of sliding lung together. If you're a little bit lower, I suppose your liver and your diaphragm can look a little bit like that. But once you kind of get used to the images, you'll know, you're like, hey, I'm a little bit too low. But anything up here, you'll never see that kind of movement if they have normal sliding lung in those areas. Now, when you have a pneumothorax, what do you think happens? Well, if you have a pneumothorax, that lung drops away. And once you have any distance, any air between those 2 viscera or pleura, you're not going to see that sliding anymore. Okay, and I'll show you some ultrasound images of what it looks like. This is a prototypical image of a lung sliding. In this image, we see the ribs here, followed by the rib shadows. And so I know this hypercoic line just below it, that's kind of quivering back and forth. Some people call it ants marching. This is lung sliding. These little bright white lines are those comet tail artifact, now called Z lines. Right? They're not quite as dense, and they don't all go down to the very bottom of the screen. And so this tells me in this part of the lung there's no pneumothorax. Guaranteed. So what does a pneumothorax look like? So in this image, same kind of location. This is a rib shadow. And the pleural line is right here. What do you guys notice about that pleural line? It's kind of flexing a little bit because the person's still breathing, but you don't see that nice glimmering, shining, sliding movement. You don't see any comet tails or Z lines shooting down from there, right? So that's what a pneumothorax looks like. And this can detect the tiniest pneumothorax. It's not as good as CT, obviously, but it can detect 1% pneumos very easily as long as you're over it. That's the caveat. That's why it's not 100%, because if it's a very small apical pneumothorax and you don't put that probe directly over the apex, you won't see it. But I guarantee you, anyone that has a clinically significant pneumothorax, you'll see, because it's going to really cover the whole anterior chest in a supine patient. So we'll go through a little pop quiz for you guys here. So which one is a pneumothorax?
Left side.
Yeah, all right. So you see, this is the lung sliding back and forth. You see tiny little Z lines coming off there. This is the pleural line right here. It's contracting because the intercostal muscles are moving, but there's no sliding. Okay, any questions? Yes, sir.
Sometimes they talk about the lung pulse sign, or and there's also the lung point sign. Or do you specifically look for that, or do you see the absence of?
I would say this is so good, I very rarely need to look for lung pulse. Lung pulse is often used for people who are ventilated because they're not breathing. So you can actually, if you see pulsations on the M mode, you'll know that there's no pneumothorax there. But because you're able to see those pulsations transmitted through the lung tissue vibrating. But I don't look for that because this is so easy that I almost never need to use it. It is a nice finding someone found, and great for them, but it's not really necessary.
So can you see this like in patient like 400 pounds or 500 pounds?
Yeah, so as you know, the linear transducer, it's very high frequency, won't penetrate through a lot of soft tissue. We are very aware of that in San Antonio. We're probably one of the fattest cities in the country. And so you just switch to the curvilinear, a lower frequency probe, and it penetrates 16 centimeters, 25 centimeters. Okay, so as long as you can get down, penetrate through their body with the lower frequency stuff, it will see that sliding. It's very easy to see. So this is a slightly different image. This is, this one's, you'll see the rib and rib shadow here, and you see no lung sliding there, except now you do. This is the lung point, okay? And this is actually exactly where the pneumothorax starts and finishes. So I'm seeing the edge. So I can actually use the ultrasound to measure how far that pneumothorax is going. If I keep going, no lung sliding, no lung sliding, and then I see lung sliding, I can see it's right over here because I see the lung point. That's where that pleura, the two pleura are rubbing together. Okay. Any questions about that? This is pathognomonic for a pneumothorax because of that lung point. All right, so M mode. Some people like this technique. Some people have a hard time seeing that shimmering. Everyone, kind of like some people are photogenic. Some people are echogenic, I guess, and some people are not. I'm sorry. In this particular image, what happens again is you put the probe on the patient in B mode. You put that M mode line in between the ribs, and then you hit on our machine to hit M mode again, and it starts to sweep across. And so what you're looking for is something called Sky Ocean Beach. Got to use your imagination here a little bit. This is sky, and this is the ocean, and then this is the beach. See how it looks just very granular? All right, this is the pleural line right there. And that basically tells you there is lung sliding and therefore no pneumothorax. So this is what a pneumothorax would look like. Instead of seeing sky, ocean, beach, you just see what looks like to be a barcode sign, or some people call it no beach. And this tells me they have a pneumothorax. There's no lung sliding. So another test. What do you guys think? Is it sky, ocean, beach? Sky, ocean, no beach? No beach. So that means there is a pneumothorax there. All right? Very easy. How about this one? Pneumo on the left, that's correct. So you see sky, ocean, beach, sky, ocean, no beach, or barcode sign. Good. Now, I assume you guys run till about 1 o'clock, is that correct? Yeah. So it's up to you guys. I can go over another kind of case series with ocular ultrasound, or we can I can tell you a little bit about what it's like to be in the military. I just have some kind of pictures of some deployments I've had and just my life as a ER physician or a military physician. Depends on you guys what you'd like to do. Any thoughts?
Case study.
Both. It's up to you. I can say as long as y'all want. My flight, we don't need to leave till I think 3, but.
We don't see many ocular ultrasounds, so
Okay.
I think that's
So I'll go through this, and then if you guys get tired of this, please let me know. So this is another wonderful use of this technology. I'm sure you guys in medical school tried to do a fundoscopic exam, but even ER doctors are supposed to know how to do it. Half of my residents cannot do it. I fortunately learned the skill, and I think I'm pretty good, but I would still rather do ultrasound. Why? Like we talked about in medical school, you're trying to learn physical exam to feel and see into people's bodies. That's crazy. Why don't I just see into someone's body, right? I mean, that's why you guys will never be out of a job, because we order more and more tests, because yeah, I think it's probably not broken, but let's order the x-ray anyways, right? I mean, that's what we do, because we want certainty. Patients expect it. In the old days, someone would not really present to the doctor until they fester, and they have this obvious, like their leg's about to fall off. Nowadays, I have patients that come in with, I've had this problem for 30 minutes, and you're like, well, I don't know what's wrong with you. You haven't had enough time to develop disease so that I can see it. But with these tests, because your tests are so great, that's why we order so many tests. I mean, you guys are a victim of your own success, I suppose. You're too good. So here are some of the basic uses. If you have a guy like this, particularly we get a lot of assaults in San Antonio, this is actually not, this is not that bad. Often you can't pry that eyelid open, but I need to know what is going on with their eye. I can just look with an ultrasound and see if they have a pupillary reaction. I can look for something called the optic nerve sheath diameter, which we'll talk about in a second. Foreign bodies, retinal detachment is probably the other big thing we look for. Patients will often come in with, I've got this funny vision thing, I can't tell you what it is. Well, can you describe it? No, I don't really know how to describe it. Well, you know, it makes it very hard. If you can't tell me what's wrong with you, I can't guess. And so I can just see into their eye and see if they have anything serious. So here are some of the indications: decreased vision loss, whether it's traumatic or atraumatic, any kind of trauma, and then we'll talk about how to use it for increased intracranial pressure. Here's the basic anatomy that you need to know to get familiar with these images. Generally put the probe on the closed eyelid because patients don't like gel inside their eyeball. And you have the cornea, anterior chamber, lens, posterior chamber, or vitreous, retina, and then optic nerve. Those are kind of the key parts you need to know. This is a cartoon of what it looks like on ultrasound, same kind of thing. So again, this is basically the cornea or anterior chamber is here. These are the iris, lens, choroid body, and then basically the sclera. And this is vitreous here. Because it's fluid filled, it of course would be black on ultrasound. This is the optic nerve. Creates a shadow-like appearance. And then with power Doppler, you'll see sometimes the central retinal artery as well. Okay, so it's very simple. There's several ways to do it. I tend to do it this way, where I just pile a bunch of gel on their eyeball. And then I kind of rest my hand, instead of kind of resting in the air, I actually rest it on someone's nose or the cheekbone, so I'm not pushing into the eye. You know, particularly for ocular trauma, if it's penetrating trauma, you don't want to put any pressure on that eye. And so you can really, other than the weight of gel, you can put that on and just float it in the gel without adding increased pressure to the eyeball. So some people put a tegaderm or one of those opsite, clear bandage things so it doesn't get into their eye. I find that's suboptimal because it just creates too many little air pockets. And air, as you know, is the enemy of ultrasound. So this is my preferred technique. I basically take a high-frequency probe, put it on the eye, and this is what a prototypical image would look like. Again, this is the vitreous here, and this is the optic nerve. Black is good, though. I mean, you don't want anything to be seen in the eyeball. If there's something in there, then there's a problem. So we'll go over vitreous hemorrhage. Vitreous hemorrhage is actually very hard to differentiate between. Some people just have proteinaceous floaters within their vitreous, but people who have clear vitreous hemorrhages are pretty easy to see. And typically what you see is these kind of little fine speckles that are heterochoic in nature. They're not going to be quite as bright as maybe when you see the retina being detached. And also because it's blood, it will kind of be free-floating. Now, a very fresh bleed, as you know, fresh blood will often be anechoic and you won't see it, but with any time, all blood clots and starts to form fibrin, and then you'll see kind of these echoes internally within the eyeball. So let me show you what it looks like. So this is a very subtle vitreous hemorrhage. Just these hyperechoic little speckles is all you would expect to see. In more extreme cases, you might see a meniscus or kind of a little more debris kind of built up. This is a vitreous filled with blood completely. And then this one is a horribly injured eye.
Is that the optic disc elevated in that
Yeah, so that's a good question. This is not my image. Presumptively, it could be, but that would be extremely elevated.
Certainly.
Extremely, yes. Yeah. As you'll see, there's some images where you'll see a little divot, and that's the, because it all dives in through the optic nerve canal. And I don't have any images here, but you'll sometimes see a little subtle, we'll see if I have one later on. Here you see this subtle little hemorrhage down here. This is occasionally capturing the optic nerve as well there.
Actually, that it doesn't appear to be too subtle. That looks like a subretinal hemorrhage. That one, that's associated with sudden increased intracranial pressure or head trauma. That's behind the vitreous.
Behind the vitreous.
It's in between the vitreous and the retina.
So retinal detachments are a little easier to see, and really, for most ER physicians, if we see any sort of abnormality within the eye, we basically will ask our colleagues to come see them, or send them to a place that does have a ophthalmologist. The cartoony picture will show kind of a hypercoic, kind of ribbon-like object that is attached to typically the optic nerve. Here are some kind of pictures of detachments here. Like I said, if you see anything other than black, it's kind of a problem for us. Here's another one as well. So usually with movement, you'll see it kind of float around, kind of like you can imagine a sheet in water kind of would move. So vitreous detachment is also can look similar to a retinal detachment. Anytime we see anything that looks like a retinal detachment, whether it's vitreous or not, we will often ask our ophthalmology colleagues to come see the patient. It tends to be a little less hypercoic in nature. It often may it may not kind of be attached at the optic nerve. So here's one down here. The other kind of use that we're using this technology for is to look for increased intracranial pressure. This is not particularly useful in a hospital-based setting, but certainly in a combat setting, we're using this kind of when you don't have a CT scanner readily available. Usually our CT scanners in a deployed setting are typically in 2 or 3 locations within a whole country, so we have to fly them into a certain location. But these ultrasound machines, because they're so portable, are available everywhere. One of the things you can do is look for increased intracranial pressure. So basically, the cranial or the optic nerve kind of is attached to the dura and arachnoid, and so any increase in the intracranial pressure will kind of transmit through that canal, and you'll often see it as a dilated optic nerve sheath. This is kind of what it would look like, a normal nerve sheath, I'm sorry. When it's basically dilated or there's increased intracranial pressure, you'll see this effect. Here's a prototypical view. What you want to do is you basically find the optic nerve, and you want to measure 3 millimeters down, and then typically we measure across from there. 5 millimeters it's probably as close to the consensus number as abnormal. There are some other people who recommend higher numbers depending on what you want for your sensitivity and specificity, but I think most people would say 5 millimeters is considered abnormal. How does this perform, and how good is this? So in this particular systematic review, they basically identified a number of studies. And of those studies, this is their composite sensitivity and specificity for increased intracranial pressure. So pretty good. So there are some age-related changes or differences. For most adults, we just stick to 5. Okay? The big caveat to this particular use of ultrasound, though, is if you are not on axis with that optic nerve, you can certainly create the shadow that looks a little wider. So it's a little hard to make it artificially small, but it's very easy to kind of make it look dilated and abnormal. So how do we use this then? So like I said, if I had a CT scanner, I would just get a CT. But there are certain patients in the ICU who may be too sick to move out of the ICU, or if you're in like an austere environment like I sometimes find myself in, you could certainly use this to help kind of triage patients for who needs to go right away versus who may just have a concussion. Here's some measurements of incorrectly measured optic nerve sheaths. Here's a case of a patient. What do you guys think of this one? Here's the measurement. So measurement's 0.74 centimeters, so too big. And this is what happened to him on CT. There's some other things that are sometimes found. I wouldn't say I usually ever look for these. Often these can be post-op patients, maybe someone who has a cataract surgery. But you can certainly see lens dislocations and so forth. Foreign bodies can be seen, or gas can sometimes look like this. This one's a gas one as well. And then sometimes I would never really go looking for this. Again, I would prefer to get a CT. But if I saw maybe someone had proptosis, I might look and see if they have like a retrobulbar hematoma, but not something I commonly do. All right, so the last part here is just kind of going to a couple of things, the future direction of this kind of technology. So this is some of the environments some of my colleagues work in. As many of you know, you may have seen these kind of devices coming on the market. This one happens to plug into an Android device, just through a USB. So it's not long before you'll see medical students carrying these around. They just plug it in, and they can carry this around with them to the patient. Now, wouldn't it be nice if I combine those two things with someone who has very limited training in this, because there's a lot to learn in medical school, right? What if I had a algorithm that could analyze and read this image for you? So this is some of the research that I do, actually. Basically, this is an algorithm that is basically interpreting this B-mode image for lung sliding, and it basically can tell me yes or no is a pneumothorax. So this is something that could be installed in these kind of Android platforms and in these newer devices, and hopefully in the future will be coming to a machine coming to you in the near future. There are some other folks that are doing very similar research out of MIT. They basically are using the same kind of software not the same kind, but the same kind of idea to use software to interpret imaging. Here they're looking for B lines and counting B lines with software to kind of make an assessment of those images. That's all I have for the educational part. Does anyone have any questions before I move on, please?
For the ocular portion, one thing we see, like we get CT to the orbits and had a lot, or not a lot, but enough for like orbital cellulitis and stuff like that. Can you see anything with ultrasound, like preset, like post-septal, like edema or anything like that, that you would, has anyone worked on that, or is that not something that's not used?
They have, I can't think of the most recent study I've looked at, but I recall it's not very sensitive. Like some people have a phlegmon and it's hard to see. It depends on how much soft tissue they have. It'd be just like a soft tissue ultrasound of other body parts. If you see a lot of like cobblestoning or cellulitic type pattern, you might say, all right, well, it looks like they have a cellulitis. But it is much harder to kind of go around and look inside the orbit, as far as I'm aware of. Someone may have more experience with that than I do. Any other questions? For those of you who want to just hear a little bit about the military. Oh, please. Sir.
Colonel, I congratulate you for a wonderful presentation. For many of us that have started using ultrasound, you have shown us an aspect of ultrasound that we were not familiar with, So, for the first time I've seen a pneumonia ultrasound, and we were talking with my colleague here, who's an expert in ultrasound too, and I haven't talked to Dr. Jonathan, that the different uses that we can have with the machine, we need to start looking at everything with ultrasound. Because the things are there, but we don't understand what we are looking at.
They're there, yeah.
It's wonderful. And let me tell you, congratulations for being a wonderful speaker. You have kept us all awake. Especially after food. Double challenge. So any more questions for?
Sir.
How far back in the orbit is it useful? Can you go back to the orbital apex or to the superior orbital fissure? Or how far behind the globe?
Yeah, you know, I actually don't know. I'm really, again, I'm not a radiologist by training. Okay. We, in our community, we keep very focused to very specific yes or no kind of things. So we're looking for very specific items. Is there an obvious retinal detachment or not? I would leave that kind of interpretation to you. Maybe someone else down the road will kind of think, hey, yes, I can see through this. You know, there are people using transcranial Doppler in ways that I don't use yet. Some people are using ultrasound to look for sinusitis. You know, some of the areas where the bone is very thin, you can transmit some sound through. That may work in this instance. You know, I don't really know how thick that bone is normally, so it really depends on that and what other surrounding tissues are. I mean, as you know, as long as there's not air there and if there's a lot of liquid, it should be able to transmit through there. It just depends on how it's echoing within that orbital chamber, and you know, that may cause a lot of kind of artifact that may interfere with image quality.
Traumatic orbital fractures are very common, civilian and military.
Absolutely, yes. Any other questions? Anyone interested in seeing what the military is like for a few minutes? All right, so just to give you a little of my background, I know you kind of read that little blurb. That sounds like it's a little out of date now, but I did a 3-year scholarship. I went to Virginia for undergrad in medical school, and then I spent some time at Walter Reed, and then for a year I was in Korea near the DMZ, and that was a very great. It was a good experience for me, mainly because I was an intern-trained doctor taking care of patients. The military has really gotten away from that because if you think about your intern days, you probably weren't a great doctor. I probably was not a great doctor then either. So, but it was a great experience because it really, when I went into my residency the subsequent year, it actually made it very easy because I knew what I needed to know. And that's very helpful to do. So I spent my time at Brooke Army Medical Center. This is Brooke Army, and then we added a new part. Now it's called SAMC because we joined with the Air Force, and now we're one big facility. Trained in California for the ultrasound stuff, and then this is kind of what our facility sees. It's pretty busy. So, what is it like to be in the military? If you were to go into it, there are many options. I am in the academic track. I basically have been in San Antonio off and on since 2005, except for this a couple times when I went away for training and when I graduated. But there certainly is normal community practice. We have a lot. Most of our hospitals are like regular community hospitals, as you would expect. The hours are pretty good. I think most of the time, after hours, these small places use telerads, and the active duty people go home, which is really nice for them. There's leadership opportunities. You know, I'm 39, and I just recently gave up the job to be the program director of this ultrasound stuff. But I used to run the department, which is very unusual for a 39-year-old to run a very big academic department, as you can imagine. I was the medical director for that. So there are a lot of leadership opportunities. There's opportunities if you want to go run around with infantry people who like shoot people and blow stuff up. You can do that. And then some people really want to like jump out of planes. Like one of my co-ultrasound colleagues, he like does what's called halo jumping. You know what that is? So I don't know the numbers because I don't do any skydiving, but I think commercial or whatever you can do in the community, you can do something like 5,000 or 10,000 feet. Maybe someone knows here. But these halo guys have to like where they go so high up, they like wear these oxygen masks and so forth, and he like parachutes in when he has to shoot someone, I guess. So that's available to you too. They're actually doctors of all types. We have radiologists that do this, orthopedists, ER doctors, family medicine. So they really just look for people who have great personality and are kind of motivated people. So this is my first deployment. I've been to Afghanistan twice. Most recently about 2 years ago. This is about 4 or 5 years ago. This is kind of one of the way stations, Kandahar Airfield. And I know I'm really far away when like people start putting up signs like this. It's like signs to all these different locations where they're from, and I think the nearest place was 6,000 miles, so not very close. This is why we're there. You know, the conflict in Afghanistan really evolved over time, and these improvised explosive devices, or IEDs, really became the most damaging weapon to our soldiers. And so it wouldn't be uncommon for us to get victims from these kind of attacks. They would then be put into air ambulance essentially. You know, in very early conflicts, usually they're in little truck ambulances, but once we get established and we basically dominate most places we go to, and we can fly helicopters everywhere, and we basically fly within 30 minutes from any point of injury, which is pretty good. Because our goal is to get people back from wherever they are within the golden hour. So that's our goal. So this is where I worked the first time. This is the whole base. It's a really big base. This is our hospital complex area. This is where I lived. This is the hospital itself. It's very basic. This is our kind of ambulance area. So like the helicopter would drop off a patient and they'd run in through here. This is our entrance to the emergency room, as it's called. Alternatively, this is the British platform. They use this big Chinook. This thing is like tremendously loud when it flies in, and they can carry like 20 patients on there all at once. This is kind of our work area. This is the whole ED or trauma area. Basically, we have no beds in here. We just use litters and like wheels so that we can basically, once we stabilize them, we then move them back to this area. There's a little room over here. That's where you guys would sit as a radiologist. At these big hospitals, we have basically a radiologist, typically one or two of them. And the beauty is, and the way this has revolutionized care, up until the 90s, we only had x-ray. So you'd have all these injuries. We couldn't triage them very well, and we didn't have ultrasound then. Now we have CT, 64 slice scanners that we use out in these environments. And literally, a trauma patient, we bring them over here, we scan them, and we can tell within minutes, because the radiologist is reading it as it's coming off the machine, and it's reconstructing those images. Basically, within minutes, oh, this guy needs to go to the OR versus, hey, we can watch this guy, he can go to the ICU. It's pretty miraculous, and it's really changed the way we practice. I mean, there's another great device here. You can't see it's hidden behind here. It's called the Belmont. You guys use those here? It's a rapid infuser for blood. It can put out around 250 mLs of blood per minute. So literally, people who are bleeding to death, we can just keep replacing blood as fast as they're bleeding. It's amazing. So these two things have really been instrumental to kind of really the mortality rate for victims in war now in like an American or very modern system is about 3%, I believe, which is amazing. All comers. So if you can get them to us, we can generally save them because they've kind of stood at least the first few minutes the test of time, as they say. So this is what it looks like from the opposite end. Straight back is the OR, and that's where the CT was. And then this is our little registration area. So very rudimentary, as you could imagine. So this is some of the accommodations where the commanders got to stay. This is where I get to stay in a nice little tent. The nice thing is as being a physician, you know, when I joined the military, I thought I was going to be like Saving Private Ryan now. What's that movie with Bill Murray? The Stripes. I thought it was going to be like that. People yelling at you and stuff like that. Maybe not as funny, but it really wasn't bad. It's actually, you sit in a classroom when we do our basic training, and then we do a field training exercise. And then physicians, because we're very high value individuals within the military, they kind of coddle us, relatively speaking. So I get my own bunk bed. I don't have to share with anyone. So this is my accommodations then. So it was fine, it worked. We had air conditioning that worked most of the time, so it's not bad. This is kind of a typical mess hall. You know, the food actually is pretty good. You'd be surprised. I'll tell you, the U.S. military and the U.S. government, you guys spend a lot of money to keep us happy out there, which is great. I mean, it makes a huge difference. You know, rather than eating those little MRA things that some soldiers who are in very remote locations that can't get hot meals, it's amazing to be at a very big base that most physicians are at. It's a godsend. So this is that way station. Guess where this is? What restaurant do you think this is? Can you guess? There's some clues here. Anyone? Yeah, it's TGI Fridays. So in Afghanistan, we had TGI Fridays, not at my base, but at one of those way stations. And it was conveniently located next to KFC, so a little bit of home. It's actually, this is an international base, so you know there'd be people from Australia, trying to think, Ukraine, pretty much everywhere. The coalition of the willing, and basically they all love these American places. They like. So this is my second deployment. I was actually at a relatively, this is probably the busiest trauma hospital in Afghanistan at the time. It's Bastion. It's actually a British-led hospital, and this was one of the most amazing experiences for me. My first deployment was with an all-American Army hospital. My second deployment was at Bastion, as it's called, and it's a British-run hospital. And so I actually got to spend a few weeks in the UK, learn about their medical system, and it really opened my eyes. Their standard chest X-ray is always one view. Like, if you want a lateral, you have to get a special request just for a lateral, which is very unusual. Like, all X-rays, not just routine, but I thought that was very interesting. And they had other things that were kind of peculiar, at least by American standards. So this is what the hospital looked like. It was a much more hardened structure, at least aluminum-wise. This is actually what the hospital looked like. We had, that was that ambulance entrance here. We had basically, this is our trauma area. The nice thing is the radiologists were right across the hallway here, and we had a CT scanner, 2 of them, right there. And then the image reading room. So when a trauma came in, you would basically stabilize the patient. Once we stabilized them, we'd take them to CT. If we had multiple victims, which is common, we'd have basically them bouncing between 2 scanners. I mean, the radiologist would be like reading one, next one comes off the table, read the next. Read the one, and it's pretty amazing to see. And within minutes, we can triage all these patients and figure out of 20 victims, who's really the sickest, rather than kind of guessing that. And then they could come back here to the operating theater. And then we have an ICU ward. So these are just some of the statistics, so I'll bypass that. This is what our trauma bay looked like. Basically, as you can see, it's a very big team. This is, I don't know how the traumas are run here. I imagine they don't just wear an apron, but this is another thing they do in the UK. To save money, they use these just like butcher plastic thingies, and so they figure like you can get blood all over your body, just not on your chest, I guess. So, but you know, I think American systems, you have these sleeved gown things, right? So, very interesting. It actually came off like a roll of like garbage bag thing. You just peel it off. I'm sorry? Well, maybe, yeah. You know, I'm not going to comment on that. That's very political. This is where our radiologist sat. We had actually, it was great. We had 2 British radiologists and 2 American radiologists. And so they would just take turn taking calls. And if there were like a lot of traumas, they might call the second person in. So we had 2 reading terminals. This is a primary and this is a secondary. They could read off like, you know, whatever the machine that controls the CT scanner is. So this is a scanner that we use there. We had 1 on each side. Interestingly enough, as you know, these have very strict temperature requirements, right? You know, if they're out of, so this is where all the energy in the hospital went, to making sure these things were in that perfect climate. They had like special air filters and so on and so forth. So these machines are actually pretty reliable. And for about 1.5 years, we had an MRI machine out there in this big trailer that was being used for research, but we ended up never needing it because all these blast victims have metal all over them, so you can't exactly stick them in a magnet. That's not a good idea. This is our operating theater. So again, we bring the victims in here or the casualties in here. And so it's a really great place to work because you get to work side by side with your British colleagues. They practice a little different. They actually, so I'm 39, and to be an ER physician in America, it's usually a 3 or 4 year residency. There, the average age of their consultant emergency physician when they finish their training, they're 37 or 38 years old, which is interesting to me. But really, appreciably, I didn't think their doctors were necessarily better than ours. I thought they had a higher, lower bar than us. But in general, I thought our physicians were adequately or equally as good or maybe better. Maybe a little more outside the box kind of thinkers. So, like I said, it was a great experience. Hopefully no one's British here. I don't know what they're doing with those extra years, but I can tell you, I think we do okay here. This is just what our ICU would look like, or actually I think this is the ward. ICU, because they have the monitor. Yeah. And this is my accommodations. I had basically a bunk bed with another doctor friend of mine. So. And then these were the occasional starters we have. So. Any questions at all? That's all I have. Well, thanks for your attention. If you have any questions, I'll be here until you guys make me leave. So.